And some are being readmitted when, frankly, they should not have been discharged in the first place. For example, we had a homeless gentleman who came in to have his gallbladder out. And the care plan says after the patient has a laparoscopic chole, where they just use the camera and take the gallbladder out, no big incision, it says the patient should be discharged home. The man was homeless. So as a nurse, it was my job to advocate to ensure that that patient was able to stay at least one night in the hospital, but it cost the hospital money, didn't it? All of this speed up in the system is harmful not only to patients and the system overall, but it costs more too. Because when patients are discharged without all their needs being met, on the other end, they will end up back in emergency, and that will cost the system more money. It's really not rocket science. When this happens day after day, shift after shift, nurses can't complete their work and lose their ability to deliver safe, competent, and ethical nursing care, which is what nurses must do by their regulation and to meet their professional standards. It sends us into moral distress. So the first issue is an aging population, which was touched on. Canada has an aging population, and seniors now represent close to 15%, and this number is expected to double over the next 2 decades. The proportion of those over 80 will grow at a faster rate. Seniors are more likely to have multiple chronic health conditions, requiring transition between providers and various care settings, as well as various prescription medications on top of that. For example, I have a 92-year-old mother. She was waiting 8 months in an acute care bed, waiting for a long-term care placement. She has multiple health issues, and she was separated from her husband. Consequently, when they were reunited, 2 days after they were reunited, he passed away. And so that's the healthcare system that we have now, and it's not fair and it's not right. Our healthcare system needs to adapt to accommodate the growing population of seniors by addressing their needs for integrated continuing care, which includes primary care services, access to affordable medications, both short-term home care and extended home services, and when they are ready, publicly funded, publicly delivered long-term care. The CFNU's new report, Before It's Too Late, a National Plan for Safe Seniors Care, notes both home care and long-term care are understaffed, under-resourced, and there is inadequate training available in the care of seniors for healthcare professionals. In addition, retention and recruitment of staff to the long-term care sector remains a big challenge. Addressing the challenges of continuing care through appropriate funding and staffing, home care, primary care, and long-term care would improve the quality of care for seniors overall. Next issue, health human resources. Nurses make up the largest professional group in Canada's healthcare workforce, are an integral part of the Canadian healthcare system. According to CIHI, the Canadian Institute for Health Information, the first time in 2 decades, the supply of regulated nurses has declined, and that was last year. So we're losing nurses. The supply of regulated nurses, which includes RNs, licensed practical nurses, or in Ontario they're called RPNs, and registered psych nurses, it declined by 2,360. The growing number of nurses either retiring or seeking work in other sectors may account for the decline, or a net loss of 2,824 nurses in the registered nurse supply. So among RNs who make up the majority of nursing workforce, the proportion of RNs approaching retirement age is growing steadily. Almost 26% of RNs are 55 and older. That's me. More worrying, almost a full 30% of RNs aged 55 and over in BC and Ontario are the 2 provinces with the lowest registered nurse to population ratios already. So 30% of those nurses in those provinces could retire at the drop of a hat. Then we have Nova Scotia. It has a significant percentage of registered nurses close to retirement, and also boasts the highest proportion of seniors in the country. So there you have a double whammy. Seniors who live in Ontario and BC, their population is projected to grow rapidly in the next few decades, creating challenges for the provincial coffers, because we already heard why. So, nurses will be retiring as the population ages, and the number of nurses per population will decrease overall. It sounds really bad, and it is. As the nursing supply declines, employers may increasingly be turning to overtime to meet workload demands. And I'm telling you, I've worked my fair share of overtime over the years. The CFNU's Overtime and Absenteeism report shows that nurses worked more than 19 million hours of overtime in 2014. 19 million, at a total cost of $872 million. So what that means is we could have hired a lot more nurses. As a result of excessive overtime and excessive workloads, nurses' absenteeism rates rose in 2014, putting yet an additional strain on the healthcare system. So I'm kind of feeling like Eeyore. It's really bad and it's going to get worse. In light of this data, the CFNU has renewed its call for a National Health Human Resource Plan, and a sustainable plan would ensure there could be safe, appropriate staffing levels across the healthcare system. The benefits would include high-quality care, safe patient care, lower nurse turnover, and fewer medical errors. Now, on to the solutions. A national prescription drug plan. It could provide substantial savings, as detailed in our publication. Sounds like I'm doing a bit of an infomercial for all of our research. And roadmap to rational pharmacare policy in Canada. These savings could translate up to $11 billion annually. Resources the federal government could utilize to make necessary 25% investment in the healthcare funding for provinces and territories, which could then be reinvested in providing enhanced healthcare for everyone living in Canada. In addition, most seniors have chronic conditions requiring prescription medications, I talked about already, and this innovation would enhance seniors' health by improving access to necessary treatments. So as a nurse, I hear examples of senior citizens can't afford their meds, they cut them in half. They get half of the amount of the dose that's required to maybe keep their heart from beating too fast, and so they end up in emergency. Long-term stable funding is another solution, and we've called for the federal government to return to funding the 25% of the provincial healthcare spending by 2025. So 25 by 25. And according to our analysis, that investment in the costs of provincial healthcare services could yield substantial nationwide benefits, including 59 million annual home care visits, an additional 2.6 million patients seen by primary care clinics, 7,500 long-term care beds, and 24,000 nurses to deliver the required care to all people in Canada in all settings across the healthcare system. So in closing, for those of us practicing nurses, we will continue to deliver the best care possible every day to every patient, because that's what we do. Thank you.
Merci, Pauline. Et maintenant, pour clôturer les premières présentations, c'est Bill Hall.
Merci beaucoup. C'est vraiment un plaisir d'être ici parmi vous. Je suis né en Saskatchewan, mon français c'est aussi bien que l'autre petit guy, le petit gars de Shawinigan, peut-être. It's a pleasure to be here this afternoon, and thank you so much for hosting this health debate. Here we are, over halfway through the longest federal election in Canadian history, but we've yet to find time to debate one of the key issues, areas of concern of Canadians. Now, 10 minutes is just enough time to get myself into trouble and not enough time to get myself out of trouble. So I'm looking forward to the Q&A session a little later. I'm going to start where Alex started and endorse everything he said about the Naylor panel report and add another dimension to it. Our Medicare system is about to turn 50. And like an old house, it hasn't aged particularly well because we haven't reinvested strategically in that house. I shared with Alex, I always ask my board members, what keeps you awake at night and what gets you up in the morning? And one of my CEOs, big hospital in Toronto, said, I have 300 million reasons to stay awake at night. I says, what do you mean? He says, that's the total accumulated deferred, it's echoing here, the total deferred maintenance for my hospital, 300 million. Just bought a brand new MRI scanner at about $15 million and a pitcher of 6 mil polyethylene protecting it from the elements. So we've got an old system that needs renovating. Canadians are worried. We did a poll in June of this year, and Canadians, what are they worried most about? They're worried about falling through the cracks. 70% of Canadians are worried about falling through the cracks, and they're most worried about the frail elderly, the near frail elderly, and the informal caregivers. I'll bet there's not a person in this room that doesn't have a mom, dad, mother-in-law, father-in-law, grandparent that isn't struggling to find the right care in the system. Canadians are also worried about falling behind. You've already heard that the Canadian healthcare system, I think, Alex, you used the technical term, sucks. It ranks 10th out of 11 Commonwealth countries under the Commonwealth Fund most recent report. It ranks just behind the United States. The United States exists, in this case, to help make us look good when it comes to health and health care. And with the advent of Obamacare, don't be surprised if we're right at the back of the bus with the next comparative system, unless we do something. So Canadians have these concerns. CEOs have these shared concerns. They're worried about the handoffs in the system. They're worried about placement of what are called alternative level care patients. 15 to 20% of beds in our hospitals are occupied by people who don't need to be there, don't want to be there, but have no place else safe to go because we don't have the programs in place to take care of them. Those same polls say, what faith do you have in governments to actually solve these problems, address these worries? And the numbers plummet. Canadians have largely given up on politicians to actually address these problems. And, you know, I think it was Joey Smallwood who said, I haven't had a conversation about health and healthcare that hasn't lost me votes, right? Our friend, the marathon man of Medicare in the media, Andre Picard, wrote an article called Lose, Lose. You know, we need to go from lose-lose to win-win. But he talked about it as lose-lose because politicians can't seem to win when they talk about health and healthcare. So we need to provide a venue like this and others to actually have a conversation about the serious issues facing Canada's health and healthcare system. I mentioned one of the reasons that Canadians have kind of given up on politicians is that they've tended to, you know, kind of over-exaggerate on the promise side and under-deliver on the actual side. And I hope Alex doesn't mind me sharing with him. He and I were at that 2004 First Minister's Accord at 2:30 in the morning where it was announced as the fix for a generation. And Alex Himmelfarb, then clerk, said, Bill, it's not going to fix for a generation. It's going to take a generation to fix it. So we have to be in it for the long haul. So what to do about it? Well, one thing you can't do is just sit on your hands. So get out and vote and factor in what the parties are saying about their commitment to Canada's cherished Medicare system as part of that calculation when you make that vote. From the standpoint of Canada's hospitals, who I represent, coming out of the Prince Edward Island session, what we asked, our question was, what first and foremost can Canadian CEOs of hospitals do without seeking a permission slip from governments? And as it turns out, there's a lot that we can do. There's a lot of exemplary practices in Canada's health and healthcare system. We need to shine a light on those. And as Naylor suggests, find better ways to scale them up and move them out. We have to fight the Canadian condition. What's the Canadian condition? The Canadian condition is we have to invent it again and again as we move from one province to another. Somebody recently said we have more We have as many pilot projects in Canada as Air Canada has pilots. My old boss, Madame Béchamp, she's fond of calling Canada land of many pilot projects, right? So first and foremost, we have to ask ourselves, what can we do? What can we do individually? What can we do as CEOs of hospitals or as a collective of health? Then we have to ask government to either lead or get out of the way. What do I mean by get out of the way? There's incredible red tape. I volunteer at the Royal Ottawa Hospital, and I'm the chair of the Finance and Audit Committee. And we have to file 55-page documents under MSAW and HSAW, health service agreements, as a pretense for accountability. One of the biggest challenges we have in the Canadian health and healthcare system is accountability. We ship $34 billion off to the provinces every year, and that grows at 6% per year with no accountability, no reporting back, a perfunctory sniff test relative to the Canada Health Act. And so there's been a 6% growth in federal transfers to this province for the last 4 years. You want to know what the base budget increase is for the Royal Ottawa? 0, 0, 0, and 0. With 5% growth in some of the most serious mental health cases in our area. What happened to the 6% growth? Where did the money go? Alex would tell you it was a check cut from one consolidated revenue fund on one side of Spark Street to the other side of Spark Street. No accountability. We need Roy Romano talked about accountability. We need to make sure that any net increases and flows to the provinces need to come with strings. So how much time do I have there? 45 minutes, like Alex was saying? I have 2 minutes. I want to focus on 3 areas where I think there's a need for strategic investment. And the 3 areas are these. Mental health. We need to level the playing field on mental health. We spend 7% of total healthcare spending on mental health. We need to increase that by at least 2 percentage points. And by the way, we don't need a permission slip from governments to do that. The CEOs across the country have the purview. They have the ability to make that happen. And that's what we're going to try and do, is move that extra 2 percentage point in hospital expenditures toward supporting mental health. The second area is infrastructure. Okay, that old house of Medicare. We have an accumulated deficit across the country of $15 billion. The government has a Canada Build Fund that provides for assistance for new bridges, new airports, and even new sewers, but specifically excludes hospitals. Hospitals need not apply. That makes no sense. If it's an employment effort, there's a job building a hospital or a healthcare facility in the future. We don't want to build hospitals, rebuild them. They were built for another era, when we had acute episodic care where all of us were, on average, 20 years, had looked forward to 20 years less life expectancy. Now we're older, we were more chronic, more comorbidities. We need to build healthcare facilities in the future, and there's no reason why healthcare facilities shouldn't be equally eligible to sewers. And the third and last one is the whole area so it's mental health, infrastructure, CIHR. How many of you are in this room do research? Quite a bit. Are you worried about the CIHR and the fact that the CIHR budget's been essentially frozen for the last 4 years at $1 billion? The NIH has a $30 billion budget, and Newt Gingrich said, let's double it. So that would make that $60 billion. Divide by 10, what should be the budget of the CIHR? Quick math, $6 billion. It's now $1 billion. Over the last 4 years, it's lost its purchasing power to the tune of $120 million. We need to put more money into research, to innovation, and spreading the good ideas we have in Canada. And I am out of time. Thank you very much for your attention.
Donc, on passe maintenant à une période de questions que je vais mener. Et le contexte dans lequel on a demandé aux panélistes de préparer leur première remarque, c'était vraiment en pensant aux réalités d'après l'élection et donc de penser au conseil qu'il faudrait donner au nouveau gouvernement, étant donné les réalités, les contraintes financières auxquelles ils vont faire face. Donc, je vais commencer dans cet esprit-là. Et ils ont tous souligné qu'il y a des grands défis. Et Patrick a souligné, par exemple, que déjà, lorsqu'on regarde les budgets des gouvernements provinciaux, que les dépenses sur les soins de santé sont très importants. Pauline a souligné le fait qu'avec le vieillissement de la population, que ça va exploser. Et Alex et Bill ont parlé donc des différentes stratégies telles que PharmaCare, etc., qu'on veut mettre en place. Mais ma première question pour vous, donc, c'est vous avez parlé de PharmaCare comme quelque chose qui peut générer donc, de l'épargne pour le système en tant que tel, mais vous n'avez pas nécessairement suggéré qu'il y a d'autres stratégies importantes à mettre en place, sauf éventuellement vous avez un peu suggéré que Home Care, ça va réduire les coûts du système. Mais est-ce que vous pensez sérieusement qu'on est capable de faire ce qu'il faut avec les ressources qu'on a investies actuellement en soins de santé? Est-ce qu'on peut rencontrer des défis d'une population vieillissante ou est-ce qu'il faut des nouvelles ressources nettes pour le système des soins de santé? Et est-ce que vous proposez alors couper les budgets des universités pour financer davantage de dépenses en soins de santé? Alors, Alex et Patrick, peut-être que vous voulez commencer?
There's constant debate about whether there's enough money in the system. Do we have the money to do the stuff necessary? We are not the most expensive, despite what you hear from the critics of Medicare. We're not the most expensive Medicare system as a portion of our budget. We're about 8th or 9th, but we're far from the cheapest. There's a lot of money in our system. The question is, how do we allocate it? Is it fairly allocated between federal and provincial? And the federal has backed off and the provincial has carried more of a burden. But also, how do we allocate it from public and private? And the way let me back off for 2 seconds and take the 35 minutes I didn't use before and contextualize this. Canada has gone through about 2 decades of fierce tax cutting. 2 decades of squeezing the fisc at every level, federal and provincial. At the federal level, federal taxes as a portion of our economy are going to hit lows we haven't seen for 70 years. We're going to pay less tax as a portion of the economy than we have for 70 years. That's before Medicare, before pensions, before mass education. And we've been buying, we vote for people who promise us tax cuts. We just constantly vote, oh good, a little change in my pocket. And we haven't asked ourselves the consequence. And the consequence of all these tax cuts is a culture of austerity. Now, some good things come out of that. Valuing efficiency, more value for money, caring about waste, but some very negative consequences. One of the negative consequences is we become a meaner place. The consequences of austerity and all this cutting fall most heavily on the most vulnerable. Refugees who can't get access, refugee claimants who can't get access to essential medical services. What the heck is that? Migrants, prisoners, the unemployed. We're moving backwards on child poverty. Fewer unemployed people have access to EI than ever before. And all that plays on the health system. So one of the things is we become a meaner place. The other thing that austerity does is it shrinks and stunts the political imagination. We start to think nothing's possible. We start to think we can't have Medicare. How could you ever have such a big program? And as Bill said, we lose trust in government. So how does it work? Government squeezes programs. They cut health care, they cut education. And then we ask, what's government for? Look how lousy government is. Why would I want to pay taxes to government that can't even perform? Then they squeeze some more and we hate them some more. And this is a vicious circle of erosion and distrust. Do we have enough money in the system? We don't have enough federal and public money in the system. It's going to take investments to make us more efficient. Where will that come from? It'll come from people demanding more of the governments, because we get the government that we demand, and willing to pay for a better future, because we get the future we're willing to pay for.
Alors, la question qui était posée, est-ce qu'il y a assez d'argent dans le système de prestation de services de santé? Oui et non. C'est absolument clair qu'on pourrait ajouter des sommes d'argent au niveau fédéral et au niveau provincial, ça, il n'y a pas de doute. Mais il faut vraiment focuser sur le fait qu'il y a énormément de gaspillage dans le système de santé. Some people in the United States have done a lot of work on the efficiency of healthcare systems. And there's a lot of really good analysis that shows that there's enormous waste in healthcare systems. Not waste in a crass sense, but waste because of bad organization and bad system design. So there's a wonderful organization called Choose Wisely Canada. And it has analogs in other countries. And basically the premise of Choose Wisely is when you go to the doctor and the doctor says, you should have this test, you should ask yourself the question, and you should ask your physician the question, is that test the right thing to do? Because we have lots of evidence that people are getting tests that they have no business getting. And this is a waste of scarce resources. Now, the estimates vary. Is it 10%? Is it 15%? Is it 20%? But if we could capture even a fraction of that, there's a lot of resources that would be freed up. So is there enough money in the system? Yes, but some of it's misallocated. But then the question becomes, how do you get change? And this is where the role of the Government of Canada can play a role. It can make strategic investments to incent both provincial governments but also other actors to make change in strategic areas. And so one very, very specific thing, before I spent another dime on CIHR, I'd put more money into Infoway and CaiHi. Basically, I'd put more money into information and data and knowledge about the system. In addition to Canada being a country that comes very badly on things like wait times, we're also a country that's way behind on electronic health records. It's shocking to me when I go to see my GP, I see this wall of paper files, right? A few years ago, my mother-in-law, who has since passed away, had to get an x-ray on her hip. So it was a very complicated process. We took her, and it was out in the West End here at Ottawa, and the place where she got the x-ray was a private facility, and it was about 6 blocks from the hospital. And the x-ray got lost between the facility in which it got placed. This is a huge waste of time, because we had to go and redo it, and all sorts of phone calls. If we could capture some of this, we'd be way better off. So, est-ce qu'il y a assez d'argent dans le système? Oui, dans la mesure qu'on gaspille beaucoup. Non, dans la mesure que les gouvernements doivent avoir de l'argent pour faire des investissements, et c'est le fédéral qui se trouve en ce moment avec la flexibilité fiscale.
So the question, is there an area where we are spending too much on health? Yes, and it's drugs. Final answer. We need a pharmacare program. We have to invest in pharmacare so that there's a national prescription drug plan for all Canadians. We would save $11 billion if we did that one single thing. And the government that comes into power and will implement a full-on national drug plan for every single Canadian in Canada, it'll be a win for them. It'll be a win for us as consumers and as citizens, and it'll be a win for the social determinants of health as well. It'll create a healthier society. Drugs. Fun.
So first, I'd agree with Pauline on that. As a recovering public servant for many, many years, we had people up actually till the mid-1990s, late 1990s, coming to Canada. Remember Hillary Clinton? She was here at this university in 1995, asking how is it that Canada spends so little and gets so much? We just entertained somebody from outside of the country yesterday, and the question's now flipped. How is it that Canada spends so much? And Alex is right. We're not at the top of the charts in terms of per capita spending or percent of GDP. We're about 4 or 5. But we're at the bottom of the charts on a lot of really important indicators. And let me give you one. Infant mortality rates. We've dropped from 6th in the world to 34th in the world. Not because more babies are dying earlier. We've gone from 6.8 deaths per 1,000 live births to 5.3. Other countries have blown the doors off us. They're down to 1.9. Iceland, the people we met with yesterday. And so we need to be really careful that we don't do what we did in the 1990s. Roy, I've forgiven you for closing the hospital I was born in Fillmore, and the one in Grenfell where my mom might just pass away. We needed to make that choice back then because the debt to GDP ratios were out stratospheric, right? We have the lowest debt to GDP ratio, to Alex's point. We can afford to spend, but let's not spend like reckless sailors. And let's not apply the brakes so hard on Medicare that we put Medicare through the windshield like we did in the early 1990s, where deputies met in Banff and cut back medical school enrollment by 10-15%, nursing enrollment by even more. We had one-way tickets going down to Texas and a net outflow of Canadian physicians in excess of 725 a year, at a net cost to the public trust of over $1 billion a year. Let's not do that again. And I see early indications that we're just indiscriminately hitting the brakes. So I guess they've been around too long, Alex. We've been around too long. We've seen this movie before, and we don't like how it turns out. Where are you going to go? Where to save, in addition to, and this is going to get me into trouble with my old employers at the Canadian Medical Association. I think we need to bundle payments. If you look at the regionalization of budgets in this country, everything's regionalized except doctors' budgets. And if you're going to, okay, so I'm getting one thumbs up, I'm sure I'll get a few thumbs down. This speaks to the issue of accountable healthcare organizations coming north from the United States, like Kaiser Permanente, like the Maryland system. We need to have physicians within those budgets so that we can move the money around more efficiently and effectively. So that's, in addition to drugs, let's get better value for money under what we spend on physician services.
Let me pick up on pharmacare, because all of you seem to think that pharmacare would be a great thing, and you're claiming that pharmacare would generate savings, and I actually happen to believe that's true too. So we watched the United States for years and years struggle with introducing a publicly funded system for healthcare. Finally, Obama made huge progress in that direction. Why are we watching the same movie here in Canada with respect to pharmacare? What is, if it is that obvious to so many people that we should be doing it, what is getting in the way?
Some of you may remember Kim Campbell. Kim Campbell was a prime minister very briefly, and she was quoted more or less accurately to say something to the effect that elections are not a great time to talk about policy. Well, the good news is this election actually might be proving her wrong, in the sense that one of the consequences of a long election is we actually have quite, actually, I think, reasonably robust policy conversations. The question is, why haven't started talking about pharmacare? It's not for lack of trying. There's a rather sophisticated lobby, I've been quite impressed, trying to put pharmacare on the agenda. And it's partly because it's complicated to explain to people. It's not that complicated, but it's just complicated enough. But it's partly because it would require a fair bit of courage on the part of the Government of Canada. And it's also because it would require extraordinary negotiations between the federal and provincial governments. Because right now, if you are old, if you are very young, if you are very poor, depending on the province you live in, chances are your drug will be paid for by the provincial government. But if you're reasonably middle-aged and you have a good job, your drugs are either paid for out of your own pocket or they're paid for through employment-based insurance. So the first challenge is to put all that together, not a simple thing. But the second part is the provincial governments, even while they might endorse the idea of pharmacare, they can't afford it. So what we would need is some sort of major deal where the Government of Canada would put up some serious dollars, and you have to invest dollars to save the dollars. To get there would require a rather complex and sophisticated agreement between the federal and provincial governments. It's actually not that hard to imagine. Before the 2004 Accord, premiers suggested just that. But to get there, we're going to have a rather intense conversation, and it's a habit that we're not in the habit of a conversation we're not in the habit of having.
Patrick, no. No, it's as easy as saying, let's do it. In 2005, all the health ministers across Canada in every province and territory and the federal government came to an 11-point plan, an agreement on a pharmacare plan for Canada. That easy. Right down to the details of how it would work and the funding allocation. Everybody agreed and the federal government said no. So why? So is it complicated? Everything's complicated, or it's totally doable. It was almost done. Why? Because yes, it is a huge cost burner, But to save money, the federal government would have to spend money. So what you're moving is you're moving money from our pockets as individuals and the provinces and businesses, and the federal government's taking on more, but it's freeing us. So right now we have out-of-pocket expenses that are huge. Businesses pay for drug plans to the extent that they offer them. Provinces pay a lot. So a good plan will require the federal government to pay all or some significant portion of the total, then all of us save. But when you have a federal government that cares more about the health of its fisc, the health of its treasury, than the health of Canadians, you have a problem. And I don't know when fiscal health became more important than human health, but when that happened, it became more complicated to have a drug plan. But could we have a drug plan? Tomorrow. And is it complicated? Sort of. You know, writing an essay is complicated, but you know, you do it. So yeah, there's not a big issue that we couldn't say, holy smoke. I was going to say worse than that, but holy smoke, that's complicated. Well, we have Medicare. That was complicated, but we had the will, we had the commitment, and we didn't have this kind of stunted imagination that nothing's possible and everything's complicated.
Comment on that. Medicare did not go through an uncomplicated birth. 23-day strike in Saskatchewan. It took provinces by the installment plan to go in from 1966 to 1971, 1972. So we didn't insist on everybody jumping on the bandwagon at the same time. So Canada has this history of incrementalism rather than radical change. The other thing that hasn't been mentioned, and it is doable, anything's doable where you've got a clear and compelling vision. What's missing here is a clear, compelling consensus around a vision on how to get from the current state to that future state. And here's the big hiccup, and it hasn't been discussed. Supplementary drug coverage in this country is worth about $14 billion to the health insurance industry. Do you think they're just going to lay down and say, by all means, expropriate $14 billion of the Canadian life and health insurance industry's business? That wasn't addressed at Niagara-on-the-Lake, Alex. It's never been addressed, and it's vested interests, as usual, that create the biggest hurdles for us moving forward with something that was recommended by Justice Emmett Hall back in 1964. So I think we need to get our minds around compensation, intellectual property. You just don't walk in there. And Medicare, we didn't just walk in there and take over the Physician Services, Inc. We compensated the insurers at the time. And then what did we do? We also said, once it's done, you don't get to compete with this anymore, right? We carved out, parallel competing health insurance plans.
Just 2 minutes. No, just 2 minutes on this, because it's a huge issue. 2 minutes. Just 1 minute. 45 seconds. The number one, the estimates on how much we would save on a pharmacare program are around $10 billion. But the way it would have happened had it been agreed, it would have been about $4 billion because of compromises with the pharmaceutical industry, so it was thought about. Number one. Number two, when you do a federal-provincial negotiation and you build something big, it's messy. There's yelling, there's screaming, there's rarely hugging, and the media look how chaotic it is. And we somehow or other we've come to value neatness more than results. So yeah, there might be some messiness as you get there, but the results are worth it, and we should be more willing to engage in some messiness.
I'm wanting to open it up to the floor, but I want to just give Pauline an opportunity to speak to this issue first.
Thank you. So we are the only OECD country that doesn't have a comprehensive national drug plan. So other countries have done it, so we can do it too. I totally agree. I support the national drug plan idea, and it can be done. We just need to roll up our sleeves, political will and all that jazz aside, jurisdiction. Let's just get it done, Do it.
Okay, thank you. Okay, now I'm going to open things up to questions from the floor. Just so you know, Pauline has already noted that she would take questions only in English. You may direct your question to whom you wish. Si vous souhaitez donc poser votre question en français, vous êtes bien entendu le bienvenu, mais les conférenciers vont répondre dans la langue de leur préférence.
Thank you. Just picking up on Mr. Himmelfarb's point about the culture of politics really being to lower taxes and lower services. There are, of course, other places where some quasi-form of insurance is actually paid in a more direct manner, as in not through general revenue. Of course, our unemployment insurance program is quasi a separate fund. In certain provinces, provincial car insurance has been nationalized and done with a lot of cross-subsidies. So it doesn't seem to do anything really in principle that would terribly violate our publicness of potentially really reinforcing this idea that you get what you pay for and making this something that people think seriously about. What is it that my money is buying for me in this very restricted domain? The only people who hate that is the finance department people. But apart from that, this makes so much more sense, I think, and there are options. I mean, all sorts of interesting models, including what the Australians do with having a mandatory requirement to buy insurance. It isn't all national. There's a lot of competition. So why isn't this ever seem to be on the national discussion, which is really taking this away from just the slush fund of the general revenue, and breaking any kind of sense with the customer of what they actually pay to get a bundle of services?
I think there's an enormous good sense in what you're saying. You know, there's a proposal that's floating out now that all health funding should be the HST. The HSC should go entirely to health, so that when provinces want more money from the federal government, what they're saying is, let's raise the HST. So you're making it very concrete that that is for health, and that might change the perspective. And I actually think there's a lot of merit to that. But if you look at, you know, Ontario decides it's going to increase premiums to enhance the pension plan, and they're attacked as another tax. It has gone so deep that anything that's compulsory is seen as feeding this, you know, the success of the right. If I can be ideologically for a moment, the success of the right has been to equate government with waste and inefficiency and to paint tax as a burden and a punishment that we should avoid, instead of the price we pay for the kind of country we want. And that's a very tough conversation to shift.
Tax as a price for your public services you receive.
There's an extraordinary book that everybody should read. It's extraordinary, written by one of the most brilliant Canadians. It's called Tax is Not a Four-Letter Word. I may have been the guy who wrote that, but it talks about how important, with my youngest son, by the way, how cool is that? And it talks about the importance of changing that conversation.
I guess the only thing I would say is that what makes healthcare different from almost any other conversation is that it's a place in which you can actually engage people in an idea about being citizens and the solidarity as between citizens. So while I'm not a fan of dedicated or hypothecated taxes, I would concede that it is a place to, I think, if we're going to break the culture as tax is a dirty word, it's around healthcare, and getting people to think about, as Mr. Romano encouraged us to do several years ago. So what is it about Medicare and healthcare that we like? Well, it's as I said at the outset, that we're sharing risk. How we would get there, I don't know. Just by the way, yes, pharmacare is complex. I think it's a brilliant idea. My only point was to say, the way election campaigns are organized, even this one, which has been policy rich, they're not a great vehicle to have that kind of conversation. Maybe they should be, and maybe it's because no one party, except for the Greens, have embraced it completely, but it's not a conversation we're having at the moment.
So just very quickly, one of the first principles of public policy is them that raise the money ought to be held accountable for how that money is to be spent. And so we either hold the provinces to account for $34 billion, and it's a farce right now in terms of any accountability associated with that $34 billion, or we're going to be forced to consider those second best or third best options, like convert the HST and transfer that tax room to the provinces. And then you lose, as many people would acknowledge, no cash, no clout. If you don't have any cash, then forget about putting any kind of conditionality that helps us even at a most basic level talk about a national system with national criteria and conditions.
Yeah, sure. So there was a study done a few years ago by the Canadian Health Coalition, and the question was posed to Canadians: would you agree with an increase in your tax level if it went directly to healthcare? And overwhelmingly, the answer was yes. Canadians get it.
Okay, next.
Thank you. I'm Dr. Ivy Bruchot. I'm with the Telfer School of Management, a professor of health administration. Pauline, you raised the really important issue looking at the health workforce. And the health workforce tends to be kind of invisible sometimes. They are our healthcare system entirely. How we best utilize those health workers to make sure that how much we train them, that they're actually able to do those tasks that they're trained for out in the field. So we talk about the waste that's in the system and not utilizing their resources completely. So we have some inappropriate utilization where there isn't appropriately trained healthcare professionals working in older adult care, but some areas where we don't utilize them fully and completely as we could. So I was wondering if you could speak to that and how other countries have been dedicating resources to better studying this and better implementing more innovative models that draw upon our health resources.
Great question. So in Canada, we have been moving ahead with nurse practitioners, for one example, for rural and remote areas that nobody wants to go and work in for whatever reason. And so nurse practitioners are really climbing the ladder here in Canada. As far as expanding the scope of practice and roles in the healthcare system overall, you think it's hard to get the territories and the provinces and the federal government to sit down and chat? Wait till you put some doctors and nurses in a room. Now there's a challenge because they all have their own jurisdiction about what they think the level of care that each of the areas should be delivering. So first things first, I think we need to break down those barriers. So we do have multidisciplinary teams, and in certain areas, we do have pilot projects that are doing just that with having great success and very positive patient outcomes. Thank you for the question.
I'll pass to the next question from the floor.
Hi, I'm Colleen Flood from the Faculty of Law here and long a student of health policy. I'm thrilled, that everyone's hot to trot on pharmacare, but we have been for decades and still nothing much has happened. And as everyone has discussed, even if and when we do that, we'll only be playing catch-up. And we won't be actually addressing, the next horizons, which, as Bill has said, around mental health care, long-term care, dentistry. We fund dentistry appallingly badly, don't even fund the most lowest income kids in Ontario very well. What next? What in 10, 20, 30 years is going to be the future of healthcare? Well, I can tell you it's not what we're doing right now. And our governance systems and our healthcare framework is all set up to perpetuate catch-up. And none of what you've said tonight is going to do anything about that. So what would you propose so that we could put in place, if there is a new federal government, a new form of a Canada Health Act that will actually work for us for another 50 years?
Two things, Colleen. One is, I like the idea that Naylor's put forward of having some kind of innovation panel that looks to the future and then works backwards. And funding it $1 billion, ramping up to $1 billion a year to do the kinds of things we need to do to scale up all the good things that we're already doing in Canada, I think is one answer to your question. The second one is to, quite frankly, some people like to think of getting politics out of health and healthcare. This event and others like it should be trying to get healthcare back into politics or get politics back into healthcare. So those are the two things that I'd do.
Very quickly. Someone once said that to govern is to choose. And I would add to that, to choose, you have to have good structures and you have to have the right people around the table. And so we have a long list of things we could do in healthcare, starting by investing in the social determinants of health, but also how do you choose between investments in mental health versus pharmacare? Well, it seems to me the answer is you have to have the people who have those responsibilities around the same table. And so with the exception of 2004, or the health deal, we have not had a conversation nationally about what kind of healthcare we actually want. We haven't forced the politicians to engage and do the trading and the difficult negotiations that are required. It seems to me that's a basic first step. Having said that, then to choose also is, well, what are we willing to pay for? And there I would agree with Alex, that it's time that we actually create the link between the taxes that you pay actually give you real stuff, and the real stuff we seem to like, because we love our healthcare system, for whatever reason, is the healthcare system. And I think that's a conversation that we need to have that we're not having.
We're under a lot of pressure to bring things to a close, so I'm going to ask this gentleman to step forward and ask his question.
Okay, so what I was wondering was basically, generally the healthcare systems are constitutionally a provincial priority, right? So is it not more, as you've said before, it's a lot of work to get the provinces and the federal government to sit down and discuss this? Is it not, in your opinion, more efficient to just transfer more funds to the provinces and allow them to choose what's the most optimal way to spend these funds instead of arguing about healthcare on a federal level?
Well, you're describing the system that we have now. I mean, that's basically what's on offer. And there are risks, and obviously that's neater than this messy federal-provincial stuff. But there are risks to it. In a federation, you have always the balance of flexibility, so that you have the diversity of needs and laboratory of innovation at the same time as you are investing in solidarity and common citizenship and common purpose. You know, we are one country and a federation, and the notion that you could actually leave it to the provinces who might not have the capacity, you are going to guarantee 14 disparate systems with huge inequities and a potential for a race to the bottom. So yes, it's a provincial responsibility, but even in our Constitution, there's a recognition that both orders of government have a responsibility to ensure equality of opportunity, equality of access to essential services of reasonable quality, and at comparable standards. So we know that it's not simply okay to say, yes, it's provincial, let's go, because we are also a country of shared citizenship.
Pauline to respond as well, because I think she's looking as though she'd like to, and then I'm going to ask.
Let's not forget that the federal government is also a regulator of the healthcare system. So the Food and Drug Administration, they regulate what we put in our bodies, they regulate the medical devices, the medications, and all of that. Let's not forget that the federal government also has a regulation role. They're also the 5th largest provider of healthcare in the country. So they provide for First Nations, they provide for the military, and many others that I can't think of off the top of my head. Oh, it used to be the RCMP, but not anymore? Oh, well, there you go. So they're a provider, and they're a funder, and they're a regulator. Those are 3 big pieces that the federal government still needs to be involved in at all levels.
We're going to move to our last question.
So fascinating and very important discussion. Just a couple of points. One is that pharmacare, we do need political parties and federal leadership, political parties to speak up on it. Just want to correct Professor Fafard. It's both the NDP and the Greens have come out on pharmacare. 2.6 billion the NDP has proposed putting in, which is far more, frankly, than the Greens have put in. But not to get political, we need the other two parties to actually speak out on national pharmacare. The other issue that hasn't been discussed is the role of trade agreements on binding our governments. We would not have pharmacare or not have the Medicare itself if we were in the position we are now with the trade agreements that we've signed. We would not be able to put in that system without massive payouts to private, the doctors or private insurance. So we are binding our future generations with these trade deals. There are positives to trade deals, but we have to look at these things objectively and not just sign on the bottom line without being objective. Well, if they want to comment on the trade agreements.
Yeah, absolutely. Okay.
So you raised the question of trade agreements. It is the case that not only do we live in an era in which tax is a dirty word, but we also live in an era in which trade is supposed to be to solve all our ills, that we will become richer, better off. And while that's probably true at some level, trade agreements have been mechanisms that have handcuffed governments in all sorts of different ways. On the specific question of health care, though, I'm not sure I share your despair. Yes, governments are constrained, but maybe not all that much. I think the bigger question becomes, in a globalized economy, one of the things we know is that even something as local as healthcare, there's all sorts of connections now, whether it's through the drugs we take, the price of the drugs we take. There's also huge amounts of movement of health human resources between countries. And so there's a whole international dimension to this that we don't talk a lot about, which is only going to get more complex. And yes, absolutely, you wouldn't want to close off opportunities for change through trade agreements. But I think that if I had to make my list of things to do in the healthcare system, I wouldn't put trade agreements in the top 5, which with this instance is not important. It's just, it's not a burning bush, at least as far as I'm concerned.
Hello. Two very quick comments. First, you're quite right. If we had to sign off on all of these free trade agreements today, we probably wouldn't have Medicare. And in fact, when we were negotiating the free trade agreement with the United States, that was not easy to negotiate to make sure we protected Medicare programs in that context. Second comment is, I doubt very much whether the price of drugs will go down as a result of signing off on the European trade agreement. I think drug prices would tend to be going only in one direction, that would be up.
Well, I'm going to bring things to a close here, but I am going to thank all of our panelists and give them 30 seconds for one last soundbite to leave you with before we invite Mr. Romano to the stage. So.
No, 30 seconds won't do that, but what I will do is leave with one thought. We didn't address First Nations health, which is a federal responsibility and a huge and neglected responsibility, and there's enormous inequities between, but apparently Roy is going to, so that's my 30 seconds.
I guess I would just use the few seconds we have left to say two things. First, Bill talked a lot about the accountability for the $34 billion, as to say, should provinces have to tell the story of where they spend that money? I'll say this in English just to make sure everybody understands. I worked most of my career in provincial governments, as well as the Government of Canada. I'm a long-time student of federalism, and it would be incredibly difficult and actually violate the principle of federalism to actually ask provinces to account to the federal government in quite the way you describe. Which isn't to say that we can't do a better job of describing how we spend the money, but I think that it's a recipe for disaster if we think we could imagine asking provinces to account for that money. I think better was sort of the direction we went in 2004, which is to ask all governments to be accountable to Canadians.
Well, I want to thank everybody for coming out this evening, and I want to say thank you to my co-panelists here and just point out that I'm the only rose among the thorns here. I just am very passionate about get out and vote. I'm from Alberta, so anything is possible.
And final words, Bill.
Well, likewise, thank you for the invitation to be here. It's been fun. It's good to connect up with other folks with a shared vision. The healthcare system of the future is all about your healthcare system of the future. I worry about the older folks determining what the healthcare system of the future will look like for you. So get out and vote for that party that's going to be doing the most to provide for a more coherent and a better healthcare system for Canada.
Thanks very much. So we're going to leave the stage now, and my colleague Kevin Page is going to be taking over.
forget to applaud, even if you don't want to, okay?
Good evening, everyone. Tonight, I have the very distinct pleasure of introducing to you a man with a very important, very long political history in Canada. And I guess we're here under the campaign, the iVOTE-jeVOTE campaign, which is a campaign that is student-led, and which is really an opportunity to bring people together, like we've done that this week, to inspire the next generation of leaders. And I must tell you that, well, I'm no longer, I think we're always students, but I mean, my lifetime anyways, if I had to list the people I thought were preeminent political leaders of my lifetime that took on the hardest challenges, that were there over and over again, that helped build this federation in my lifetime, my short list would have Mr. Roy Romanow. He was a provincial politician in the 1970s. He served as the Premier of Saskatchewan from 1991 to 1999. Avant son élection comme Premier ministre de la Saskatchewan, M. Romanow a tenu plusieurs postes dans le cabinet provincial. Un des plus intéressants étaient ses responsabilités dans le domaine intergouvernemental lors des négociations pour le renouvellement de la Constitution canadienne en 1982. Mr. Romanow's close personal relationships within the Minister of Justice, Jean Chrétien, and then Minister of Justice for Ontario, Roy McMurtry, were instrumental in advancing the final package that would eventually be accepted to repatriate the Canadian Constitution. How amazing is that? En 2000, M. Romanow a annoncé sa retraite du monde politique, mais sa retraite n'a pas duré longtemps. He didn't stay retired for very long. In 2001, Mr. Romanow was asked to head the Royal Commission on the Future of Healthcare in Canada, commonly known as the Romanow Commission. The final report, released in 2002, made a series of recommendations to reform and renew Canada's healthcare system. En reconnaissance de ses contributions à son province et son pays, M. Romanow a été nominé membre du Conseil privé en 2003. En 2004, Mr. Romanow was made an Officer of the Order of Canada. So we get to see and listen to a very, very important person for our country. Please join me in welcoming a prairie boy from Saskatchewan, a very humble man, but a very important man in our country, and an honored Canadian to our stage at the University of Ottawa tonight. Ladies and gentlemen, I present to you Roy Romanow.
Kevin, you're a wonderful introducer. Thanks very much. Merci beaucoup, Monsieur Page, Mesdames et Messieurs. Il est un grand plaisir d'être ici avec vous dans cette université qui est très importante au Canada. Il est mon plaisir. I am bilingual. Basically, Ukrainian and English is my bilingualism. And after a few drinks, when you reference Jean Chrétien, Kevin, I could speak French like nobody's business. But this evening might be a bit of a different story. I want to begin by saying that it's a great honor for me to be invited to this great university, the University of Ontario, and to be invited to participate amidst all of you, and especially the panelists who I have listened to this afternoon. This is really an outstanding cast of characters, Kevin, that have been put together. And you are to be commended. The University of Ottawa is to be commended, one of our great institutions, for staging this event. I find it also a little bit strange. I was going to use the word weird, but I thought maybe that would be an appropriate strange, that here I am in a conference where the president of the university was the Minister of Health at the time that I was the Royal Commissioner appointed, Alan Rock, and the boss running the entire show in the Government of Canada was Alex Himmelfarb. And I'm going to be telling the president of the University of Ottawa and the chief of the Privy Council all about healthcare. I don't know if that quite works tonight, but in any event, it's a pleasure to see certainly Alex and to be in this particular venue. And also all the others as well, Bill and all the ones who have spoken in the previous panel. I've had occasion to change with them, exchange ideas with them, and learn in every case with you. So I want to begin by thanking you, Kevin, for the honor of inviting me and having organized this very important, very timely event, and giving me a chance to share a few views on this important issue of pharmacare and Medicare going forward. As most of you know, going on 5 decades now, I hate to admit that, I've always had quite a bit to say on the issue of health care. After all, I would argue that most, if not all, of my core beliefs as a politician are rooted in my memories and participation of the bitter Medicare wars in the 1960s in Saskatchewan when I was a third-year student in law, third-year student in law. The debate was so intense, the urgency of the debates remains even to this day galvanizing and vivid for me as they were at the time. 23 days doctor strike, as has been pointed out already, with only 2 or 3 doctors, as I recall, working throughout the entire province, made the environment one which was very complicated and very divisive. And I was a young student, practicing, well, at least studying to be a lawyer, and very much caught in this debate. A little confession, my father and mother came from Ukraine, father in 1927-28 and mother before the Second World War, later, and they were always of a position of great gratitude that this country would accept them, as I think most new Canadians are. I used to tease my father later on that he would always practice his English with me by saying, "Me Mike Romano, me liberal." He was so pleased that it was a Liberal government allowing him into the country of Canada. He didn't live long enough to see me become a New Democrat. However, I'm thinking that maybe we're kind of close in some ways in any event. So the urgency of those debates have persuaded me with respect to the positions, and they've influenced me, and you must take that into account in my remarks and the questions that will follow. My interest in pharmacare in particular is a natural extension of my commitment to ensuring that the values, which I think are at the heart of Medicare, continue to be given modern expression through new policy initiatives, many of which we've talked about just a few moments ago. I think that we all agree that the nature of healthcare delivery has evolved, to state the obvious, and so too must Medicare in the consequence, not only through pharma but other issues. With pharmaceutical drugs now representing the second largest expenditure in the healthcare system in Canada, it is long overdue, I argue, that our leadership in Canada makes a commitment to a comprehensive national pharmaceutical plan, as difficult as that is, with all of the challenges identified by our previous panel. The simple fact is that far too many Canadians are falling between the cracks because they simply cannot afford the prescription drugs that they need, prescription drugs which have really exploded with new technology over the last several years and decade or so. Permit me to begin by saying as well a few words about the future of Medicare in Canada and the role of our governments and the role they must play in ensuring that the principles of what I view to be our most cherished social program, principles are upheld and strengthened. It begins with values, values which are integral to our public universal health care plan. I would say, 1, treating each other with dignity, 2, caring for each other in our time of medical need, and 3, doing so no matter where one lives or what one's socioeconomic status. In the context of Medicare, probably defines some of the key values that I'm referencing. After all, Medicare is based on the inherent worth of every citizen, rich or poor, no matter what the background. It affirms that we value medical care as more than just a mere commodity to be traded, bought and sold, and managed according to the rules of the marketplace. And frankly, I see very little evidence that many Canadians today believe otherwise, although there are voices otherwise. And yet, despite this view that I have put forward for your consideration, that this sharing notion is very much the predominant ethic still in Canada, a determined group of individuals and organizations seem to think otherwise as I see it. They are intent on dismantling a remarkably effective institution with all of its faults that has served Canadians well for over half a century. For sure, there are real challenges. We heard about them a few seconds ago. Waiting times for some procedures, accessibility to certain programs, appropriateness of responsiveness of services, the disentanglement and the harmonization of various professions, and on it goes. But these, I remain of the firm view, are not insurmountable. They can be fixed. Let's just take a moment to remind ourselves of some of history's highlights leading to our achievement in the first place of Medicare as it was first constructed. First, there was Tommy Douglas's principled leadership in establishing publicly funded Medicare in Saskatchewan. Many of the arguments and questions put to the panelists just a few moments ago were reflected in that debate back in the late 1950s, early 60s in Saskatchewan. I can well remember as a student. I can personally attest to the difficult, but yet eventually successful struggle to implement Canada's first universal Medicare plan. And it was not easy. There was, as I've said, a province-wide doctor strike. Large, huge, belligerent rallies of public against Medicare, the socialization of health care, individual responsibility, all the arguments that we hear. Hospital privileges were eventually thwarted, denied to those doctors who, on principle and other beliefs, would come all the way basically from England, serving out of the NHS, to serve in the Medicare system in Saskatchewan. When they arrived, many of the establishment and hospitals in Saskatchewan would deny them hospital privileges because some of them hadn't taken 3 months internship in maternity care. English doctors, kind of a senior place for the home of the development of modern medicine. This was the atmosphere, strikes and huge debate. I remember one time going to Woodrow Lloyd's house. Woodrow was a premier after Tommy moved on federally. And at both ends, the RCMP had blocked off the roads because of the threats that were being made not only to his family and to his life, but to the other leaders like Alan Blakeney, who were involved in implementing this big change. So it's a principled and strong leadership element which is required. Then second, along comes progressive conservative Emmett Hall's landmark Royal Commission of 1964, after the Saskatchewan dispute had cooled off. A report which reflected Canadians as a nation thirst for universal Medicare, as Saskatchewan had basically set it up in principles. Emmett's commission put this agenda squarely on the national scene. And I would say it's a credit to John Diefenbaker. Note the various names I'm throwing out here because they're of different political stripes. I think something unites them, and that is what I'm going to say in a moment again to emphasize the values of Canadians. Diefenbaker, who appointed Hall, who in a thorough study, I would say the best study of Medicare in a Royal Commission report, maybe best study period, tabled his document. We still read it. And then third, there was the remarkable example of principled national leadership when Prime Minister Lester B. Pearson transformed Medicare into a truly national program. You know the story, some of you. Pearson, as others provincially, but Pearson faced an array of opposition forces. He was in a minority government position in Ottawa. The opposition came from ideologically opposed premiers, as well as very powerful and entrenched professional groups, and even to a divided federal cabinet over which he presided in this minority federal parliament. It was a tough fight. How do I know? Well, I know because a few years ago, I had the honor of delivering a lecture in honor of Alan J. McEachern at St. FX University, the McEachern Lecture. And to my surprise, I was told by the president, Sean Riley of St. FX, whispered in my ear just as I was about to take the stand, the podium to speak. He said, "Roy, Alan J. wants to say a few words after your speech." Well, I finished my talk somewhat nervously, kind of like I am right now after all of these experts have spoken. And Mr. McEachern was invited to talk about his thoughts after the speech that I gave. He described very movingly, he was a great orator, the situation facing Pearson, his cabinet, and the country at the time. He said the province has tried to take advantage of the deep divisions within cabinet. 8 premiers had confronted Pearson with major complaints, constitutional, financial, and ideological. Alan McEachern summed up Pearson's decisive leadership, which is another major theme of what I'm talking about, in this circumstance and condition. And I quote from it. These lectures are published by St. FX. And this is what McEachern said. So, it was in this atmosphere of provincial opposition and divisions within cabinet that Mr. Pearson finally decided that we would go ahead with the Medicare program. I'm going to go back just to remind you. The words that Mr. Pearson finally decided that we'd go ahead with the Medicare program. And then McEachern said, and without his decisive action at that time, because he finally made the decision, we may have lost the whole issue. To me, this is a remarkable description of remarkable leadership by a remarkable person. Not the only one in our Canadian pantheon of political leaders, but definitely in this particular discussion and debate, keeping in mind the various conflicts and the various obstacles which the previous questioners have advanced to our extremely distinguished panel a few moments ago. I go back to this decisive action whereby he made the final decision, ideological, political, as factual as he could be about it, leadership. And there we have it. A program conceived at the provincial level by Tommy Douglas and the CCF, subsequently endorsed by Emmett Hall for worthy international implementation, appointed by a PC Prime Minister, and then entrenched as a national program in a minority government by a Liberal Prime Minister. Now somebody tell me about the ideologies that are involved, at least at a political difference. I don't see them. But what these leaders from different backgrounds demonstrated is that national leadership is predicated, as I see it, on understanding and respecting our federation, and more importantly perhaps, well, let's say as importantly, but I'm tempted to say above all, understanding our nation's core, basic, fundamental values, the words that we've been using over and over again this afternoon thus far, and I guess during the course of your seminar. Values. Of course, practical issues always need to be addressed and resolved, and they're difficult to do so, and sometimes they're not easily resolved. In Pearson's case, Ottawa's federal spending power offered 50 cents on the dollar to the provinces if they joined Medicare and adopted the principles of Saskatchewan-style Emmett Hall recommended Medicare. The principles being, as we know, universality, public administration, comprehensiveness, and portability, and later in 1984, under Mr. Trudeau, accessibility, the 5 principles. And it worked. Of course the details were confusing and compounded the problems, but it worked. Within 5 years, every province had embraced Medicare. And within 5 years and after, embraced it as kind of a defining feature of what it means to be a Canadian. Not the only one, but a major one. I think this is a remarkable example of the promise of Canada and the promise of something called cooperative federalism. I commend that term, by the way, to some of the politicians federally in Canada today, and a signature sign of leadership based on values. Of course, there will always be challenges, and there were even after this period. In 1977, Prime Minister Pierre Trudeau changed the funding formula for transfers to the provinces because he believed that Medicare had become an established program. Thus, it was called EPF, Established Program Financing. Somewhat unpredictably, the new EPF formula had the effect, however, of lessening adherence to national standards put into place prior to that time, perhaps even with a reduction of money from the federal government of the provinces, with the result that extra billing and user fees for medical services suddenly emerged and surged. Through EPF, Ottawa had surrendered some of its authority to shape the future dimensions of healthcare services and to keep the system relevant and accountable, and they surrendered it to the provinces on the constitutional argument, and this is an argument that I would not say decisive that I subscribe to, that somehow Medicare is an exclusive provincial jurisdiction. I don't believe it. I think the Constitution can be read that way, but I believe it's a shared responsibility. But to its credit, the Trudeau government of that period, heeding voices such as Hall and Douglas, who came out of retirement, and thousands of concerned citizens who by that time had attached the value structure to Medicare or vice versa, the Trudeau government responded by enacting in 1984 the Canada Health Act, I say our health charter. And this was followed by a period of active enforcement of these principles by Mr. Trudeau's wonderful Minister of Health, and I believe University of Ottawa Professor Emeritus, the one and only distinguished Monique Béjean. What a wonderful individual and Canadian she is. But in most recent years, Ottawa, I believe, I argue, has become reluctant to involve itself directly, given this history, in shaping the much-needed new reforms as new technologies and new ideas of the delivery of health care develop, within the context of it being a social responsibility that all of us bear and support as a value of Canada, dating all the way back to Douglas and before or during that time. There's been a failure to enforce the Canada Health Act lately. The CHA and Ottawa have changed from a strong sentinel of Medicare's values. I argue it's changed to a rooted, non-reactive stone statute. That's basically it. And all of this in the face of an explosion of new technologies, new procedures, new medications that demand accommodation into Medicare. Prime Minister Chrétien saw this, and he took the chance of giving me the task of being the Royal Commissioner to take a look at it in that era. We already mentioned this, but I'll say it very hurriedly. After I tabled my report, Prime Minister Paul Martin then held a meeting of great importance of First Ministers in Ottawa in an attempt to see if they could get the First Ministers to adopt some of the recommendations I had advanced, rebalance the funding arrangements, and spark changes to Medicare reflective of these new technological changes. $40 billion, I think, Alex, was the number, over 10 years was added to the Medicare spending envelope. $40 billion. Restoring the traditional levels of funding between Ottawa and the provinces. Restoring the traditional levels. This was a very positive step, as Alex Himmelfarb noted and as I note. But there was one but that I would attach to this, or perhaps one but and unfortunate comment. There was no way to ensure that these funds would be applied to the areas that had been identified as priorities. They were basically directed, correct me if I'm wrong on this, Alex, to 5 medical procedures as opposed to the new evolutions in the instruments, big instruments of Medicare or health care. such as, I mean by this, home care delivery, rural care delivery, remote, electronic healthcare systems, Aboriginal care, pharmacare, wellness, and the list goes on. The funding was very important, and I credit Martin Jr., the Prime Minister. The funding was important because it bought peace, important peace for a short period, in stabilizing the system and cooling down the debate, which was occasioned by this flood of new technology that was swamping the old program. Now to today. Today, the current government's policy has been one of inaction, and that's being charitable. It has accelerated the decline of our healthcare system by not only refusing to acknowledge these new developments, and therefore, with that, to even discuss possible solutions with all the complexities that our previous panelists have described. What I guess I will say in another way is that Ottawa's involvement has evaporated. To be blunt about it, the Minister of Health is missing in action. And in the ensuing vacuum from Ottawa, with 10 different provinces, add now 3 territories, is there any doubt as to why there is so much confusion and debate about the various ways in which to handle these solutions and why Medicare may be threatened like it's never been before in Canada? Of course, and I acknowledge there's an argument for this. The current federal government argues that the role in the federation now is comprised of a view that I describe as only being watertight compartments. That federal intrusion into provincial matters for the purpose of maintaining strong social programs does not, they argue, serve the best interests of Canadians. This is called open federalism, in contrast to cooperative federalism, or even entangled federalism, however you want to describe it. Well, my reply is, this is a major departure from our nation's history, Canadians' history, a history marked by the visions of the great leaders of Pearson, Hall, and Douglas, and that more than ever, we need public policy and public political commitment firmly rooted to our values, which I claim have not yet been changed, values which will be the guideline to modernize and apply the specific solutions to these issues which abound. But it isn't happening. So where do we go from here? Well, in the shadow of the coming federal election, 4 weeks or so away, let me sketch what I think is a progressive agenda that might have a chance of being embraced. First, we need to, quote, connect the dots between public health and our healthcare system. Second, we need to better understand the social and economic determinants of health and to act on them. This is one of the biggest problems with respect to good health care. Third, we need to attack the glaring disparities in health between Indigenous and non-Indigenous Canadians. Am I glad that was raised toward the end of the panel? I live in that circumstance. We all do in Canada, but I know it well in Western Canada. A deficiency, a shortfall that is unconscionable, in my view, and is a black mark on Canadians, I believe, commitment to shared Canadian values. Fourth, we need to invest in e-health and support Canadian and provincial innovation and the sharing of best practices, ideally through an independent and effective health council that would also report on health system performance and accountability, not only to the caregivers, but to all of us, the people of Canada. And we need to crack down on the creeping privatization, maybe it's even galloping privatization, that seriously is undermining Medicare's integrity and with it the social consensus that holds it together. I'm under no illusion that Ottawa can do all the heavy lifting in this area, and I don't want to be picking on the current Prime Minister of the government exclusively. Provincial governments have not been totally helpful either, taking the view that it's a primary responsibility of their own and shaping little amendments to the program according to their ideologies and their interpretation of these programs. So it's not only Ottawa, but together, the reality is that this issue of primary responsibility being provincial, and I've got nothing to do about it federally, doesn't work any more than it does the other way around, that it's all federal and I have no provincial responsibility. We are tied together in this, in our federal system, small country, population, large distances, and huge disparities in those differences. In this circumstance, it's obvious, therefore, to me, that Canada must, as a government, play a critical role now, it's not too late, in mobilizing a pan-Canadian enterprise like they did way back when in setting the program up initially, an enterprise in renovating it. It's going to be a difficult debate in modernizing it and again restoring it to that point of, I'll say, affection, admiration, and support that Canadians have always had and I think will continue to have. And nothing better illustrates this as I begin to wind down my remarks than this issue of national pharmacare. It's not the only issue, but I think it's very important. When Medicare was first introduced, prescription drugs played a limited role in the healthcare system and the day-to-day life of the vast majority of Canadians. In fact, I stand to be corrected by the experts here, but today it's still Medicare, hospitals, and doctors. And by the way, it is now, I think, the doctors for a while that have challenged the hospital expenditures based on fee-for-service, but I could be in error there, and I defer to you, Bill, and the experts on the panel before. But that's not the fact of life today. I mean, how do we worry about protecting children from illness, curing diseases that were once a death sentence, to managing chronic health conditions for tens of thousands of Canadians? Prescription drugs have also replaced the need for some intensive surgeries. I'm not one, by the way, who says if you're sick, go get a pill. But if it's prescribed after careful and professional medical assessment by those trained to do so, we know that these prescription drugs in some areas have helped to reduce recovery times, have allowed people to recover at home rather than in hospitals, which is a good thing. And looking forward, we should only expect continued increases in both the supply of and the demand of these new prescriptions. The science will continually refine and it'll continue to grow. But the benefits will only be realized if the drugs are integrated, like hospitals and doctors are, the only ones named, into the healthcare system in a way that ensures that they are appropriately prescribed and utilized, that's another problem, and also that the costs can be managed. Thus, I argue that a government in Ottawa must make its priority the implementation of a national pharmacare plan, as difficult as it may be, a principled implementation of a key recommendation that Emmett Hall first recommended in 1964, and which, if I may say, without any sense of braggadocio, I emphasized also in a specialized report in my healthcare report. This could be done by Ottawa in one of two ways. Sitting down and trying to negotiate a pan-Canadian program with the provinces and territories. Difficult, I agree. Or initiating universal coverage on its own. Difficult, I agree. But I remind you about leadership federally on its own with Mr. Pearson in a minority government. One can argue I'm comparing apples to oranges, and they quite don't compare, but I don't agree. These are principles, the various programs are different. It is leadership based on values which is at play here. There are advantages and disadvantages to each approach, although I favor, obviously, the one where leadership, well, what I really favor first is federal-provincial cooperation, but leadership exhibited by our leaders and the Prime Minister in getting this job done. That's the way his history has taught us. But these pale, these problems, in comparison with leaving things in the status quo. Really pale in comparison. The status quo will lead we know where? To the complete dissipation and dissolution, I'm overstating and I acknowledge a little bit, of our healthcare Medicare plan. We need to have change. Again, just to support this, A recent report of the Canadian Medical Association Journal, I think referenced by our panel earlier. Canada is the second highest per capita spender after the United States. Second highest after the United States. Second highest after the United States on prescription drugs in the world, if I read that correctly. Distressingly, we have one of the poorest cost control systems in the world. This is Canada, with publicly funded health care. And between 2000 and 2010, we experienced the highest growth rate in drug spending in the world. Now, one could argue that's because sometimes they're being prescribed too liberally and willy-nilly, without care and attention. I leave that aside. But it also may be attached to by the very fact that there isn't these kind of proper controls in place through federal, provincial, and other mechanisms involving the professions. This can be done with men and women of goodwill and with leadership being exerted. And then I think, and I can say a little bit about this, I was premier for 10 years, 91 to 2001. Provincial governments are constantly being played by the pharmaceutical lobby. And in my judgment, as I saw it, the result is unacceptable variation in coverage and cost depending from province to province and where we live. The same study concluded also that a new pan-Canadian universal prescription drug plan would save Canadians. This number can vary. I heard the number of 10 billion. Okay, so I'll say it's 7.3 billion. Who's going to quarrel about a $3 billion saving? But either way, these numbers are important with respect to cost and probably sort out the appropriate use or legitimation of which drugs are to be used and to be on the drug formulary. The total cost would be enormous at saving of $7.3 billion. And the Federation of Nurses of Canada, by the way, in 2014 found similar conclusions in a wonderful report there. So I wish to be clear. Ottawa has a major constitutional foothold to take action, and in my view, the authority to establish the National Pharmacare Program, which I would argue is the most needed of a whole number of must-needed programs. At a minimum, 3 initial essential steps need to be taken. First, make catastrophic drug coverage a reality. This is part of the unfinished business, Alex, I think you agree, of the Health Accord of 2004, and one of the key recommendations of Emmett Hall and my commission report. Second, we need a new national drug agency able to complete timely and comprehensive reviews of the myriad new drugs coming onto the market annually to ensure their safety, their quality, and effectiveness. And by the way, there's a myriad of them. I don't know how many anti-cholesterol drugs there are that come out. What's the difference between some of them? I suppose somebody will write into CPAC or wherever this thing is being filmed and say, well, here are the differences. But surely to goodness this can be sorted out and made more manageable in the result fiscally and effectively. And we need in this agency, or call it what you will, the ability to monitor and analyze the use so there's no abuse and the outcomes, and to share evidence and the results widely with not only government people, but researchers, independent academics who are experts in this area, healthcare providers, and policymakers. I think we can do this, not only through various organizations, but we can do this as Canadians because we did it when the big deals back in 1962-64 were thought insurmountable. We've been making progress, but very slow and very limited, and not there yet, to put it bluntly. And third, a national formulary for prescription drugs. I acknowledge the efforts being made by the so-called Council of the Federation. My day was called the Annual Premiers Conference, but okay, it's the Council of the Federation in that regard. But this progress has been slow, and I can tell you it will continue to be slow. I hope I'm wrong, and it won't achieve success unless and until national leadership comes to the table and joins in this conversation. Friends, one of the great strengths of universal Medicare is that all Canadians, at least this is the objective, and I think essentially it's correct, although there are some disparities, that all Canadians have access to medically necessary services wherever they live, without any major financial barriers. Money should not be the barrier to good health care. This is truly one of the touchstones of our citizenship, is it not? One that the Canada Health Act is meant to safeguard and meant to articulate. It is supported by a large majority of Canadians, I say to this day. And if I'm wrong, then I would challenge one or all or any of the political leaders to say right now in this election campaign that they'll do away with the Canada Health Act and do away with publicly funded Medicare. It's supported by a large majority of Canadians for the peace of mind that it gives us. And, as important if not, it resonates with the values of nation building and the values of our great country. This is one of those stubborn facts that just can't be eliminated or wished away or not spoken about by the opponents of Medicare. Yes, there are dire warnings that our health care spending is out of control. I don't buy it, but there are these dire warnings. Yes, as a percentage of GDP, health care spending has increased over the past decade. I can't dispute that. But that growth curve has begun to decline in the last few years. And more to the point, public health care spending isn't an immutable law of nature, like gravity. Smart people created it. Smart people can fix it. Dedicated Canadians rallying around the basic value that I've talked about can do the job. We can manage the costs. We can contain them. We can invest smartly in electronic health records, in pharmacare, in home care, upstream development, keeping us healthier and more productive. And on it goes. A survey recently by the Canadian Payroll Association, as I come to an end, makes this point more bluntly than I can. I was astounded to read this. The association found that more than half of all employees, 51%, would find it difficult to meet their financial obligations if their paycheck were delayed by a single week. More than a quarter of the respondents, 26%, say they probably could not come up with $2,000 over the next month if an emergency expense arose and was needed. 1/4. Now try and make the case to these folks or to retirees on fixed incomes that they should set aside money of their own hard working for an unexpected health issue. Don't worry about government, it won't be there. You have to set aside this as a personal responsibility. And maybe eventually you may get reimbursed. I don't believe Canadians buy that argument at all. And so, friends, I say that in recent years, Ottawa has demonstrated a consistent lack of will to enforce the Canada Health Act, to engage in discussion about these issues that I've raised, rather inarticulately, I admit, but the others so eloquently by our panelists today in this wonderful conference, Kevin Page, which you've staged. As a result, there has been erosion because of this failure to enforce the Canada Health Act and to engage in discussion, erosion of the principles of portability, accessibility, and erosion to the entire healthcare program. This will stop. I'm optimistic. It needs to stop. Because I think what will beat this negativism, and I repeat on this as I close, is our fundamental values, which as I travel around the country, still speaking about health care, I don't see as having been eroded. In fact, if anything, I see strengthened in the light of what's been going on the last little while. And now we're getting some political leadership talking about the issue of pharmacare and general reform. Tom Mulcair, I think, spoke to this gathering and announced the progressive pharma plan, the broad details of which, and I think it deserves Canadian attention and consideration. Hopefully the other leaders will step up to this as well. So I think what we need is national pharmacare plan, debate in detail, comprehensive plans for health and wellness, innovation, investing in innovation, and a determined enforcement of the Canada Health Act in addition to the other matters that I touched on earlier. But above all, as I close, we need this. We need the kind of leadership of the sort that Douglas, Hall, Pearson exemplified, demonstrated, so that we can, as Canadians, modernize, reform our health care plan, and give real voice by doing so to our nation's values that we protect each other, that we are our neighbor's keeper, and that this is one of the best ways in which to put tangible meaning to that ethic, that value which underlines us. That's my belief. I hope it's yours, and if it is, then let's recommit to the goal starting now. Thank you very much.
I think we just heard one of the best speeches of the political campaign so far. But we still got a month to go, so I just feel blessed to having been here. I think we all do. I could feel the room kind of go silent in the energy, just the attention. I just feel that like we just got a lesson in history from the 1960s on by a man who's been there on all these big issues, including healthcare. And also, just again, is such a humble person. Like, this great leader that's never given up on these tough challenges. So I just we're going to come back. I know Mr. Romano wants to take a couple of questions, but I think we all feel the same. We just have to put our hands together one more time. Thank you.
Thank you very much. Thank you very much.
A couple questions.
Yes, sir.
Do we have a few questions from the audience? It's a special opportunity to talk about this important issue. A couple of questions.
So I'll just step up and say the rule that I have is I take all the easy questions and Alex Himmelfarb takes all the hard questions. So we're still in that tandem, right, Alex? Anything at all? Or is it time to adjourn? Please. Yes. Speak just a little louder, please. Yeah, a National Drug Agency. I'm not sure everybody else can. If you had a microphone.
Microphone's coming out.
Microphone's coming. If you just repeat it so that.
Thank you, sir.
Hello, can you hear me? Is it on? Okay,
yes,
great.
Yeah.
So you mentioned the need for pharmacare agency, I think, if I understood properly. And so I definitely agree with the need for pharmacare, but I was just wondering if we had an agency like that, how would it be able to, how would it work in terms of antimicrobial resistance? In terms of this might be a little out of line from the discussion, but antimicrobial resistance, since it's been a rising problem and the need to sort of control how much, or mitigate how much medications people are giving out and limit the amount of medication that's like the excessive medication that's being used and given out. I was wondering if pharmacare would play a role in that. I don't know if it's out of line to ask that.
Not sure that I'm sorry, this is my fault, that I fully have heard the question, but what I view, call it what you will, but a national drug agency, is a central agency composed of experts and also the public and government representatives. It doesn't have to be large. I don't think it even has to involve all of the provincial governments. They may object to that, which will look at the efficacy of certain drugs. I don't know how many kinds of anti-cholesterol drugs, which I mentioned in my speech, we have. And there we are, we're buying all of them, and various doctors are offering them to various people in various dosages and the like. Sometimes I get criticized when I answer that by saying, well, my doctor knows better that this particular anti-cholesterol drug works as opposed to that one. I can't argue that, but I must say that my experience traveling the country for a year and a half or 2 years, which is not much, and continuing a little bit of reading on this thing is a little bit doubtful. I think there's a range of effectiveness of these drugs which work. So I'm saying limit the choices, limit therefore the competitive nature of the costs. I'm saying bulk purchasing as well. When you face the farmers, you got to do it on a national level. You can't do it on a one-off basis. You take the best evidence that you can internationally as to the effectiveness of drugs. Different peoples, different societies, they may not work in the Canadian, but to do it in a very systematic way so that within the context of affordability, we can get the biggest bang for our buck, to put in simple terms, or terms we use very frequently. That's basically what I think is required. I know some might say, oh, well, it's another bureaucratic agency which is necessary. But I think that over time, it could gain a stature and a respectability and be authoritative, whereby medical professionals would be following this, and a guideline as to what we buy or we don't buy as a nation, so we don't buy the whole plethora of it, on the assumption we have a national pharmacare program. That's the kind of thing that I'm thinking of. Abuses and things of that nature, this is where I'm not sure I heard you, but if you're talking about that, I think requires a different mechanism, more one-on-one doctor-patient relationship, more education, maybe early childhood learning, a variety of those factors. I'm stumbling a little bit now in trying to speak to that particular issue.
Just one more question.
I can't hear the microphone. Turn up the microphone, somebody.
Mr. Romano, if there was one healthcare-related promise that you would like to hear during the federal election campaign, what would it be?
I've been sitting here for a bit of the session this afternoon. I would say that is the toughest question. If I said to you, Alex, what's the single most important one thing of all the comments that you made, well, you'd probably be able to come up with it. I would say a commitment with some specificity, if there's such a word, to it, with respect to timelines, the construct of it, not in detail, because it's going to require negotiations with the provinces, public acceptance as well, of a national pharma plan, whether it's done under an institute or some other separate organization. I'm not quite sure how that would work. I would think that it would probably, given the volume of work, and probably as a mechanism of homogenizing as much as possible across the country, the various drugs, that would probably be the most important vehicle. And in very, very broad terms, I know the answer is inadequate, something along the lines that I have generally described to you is what I would think is the priority. I say that, but I'm a little bit close off, and I want to make the speech, so don't be worried, I'm not repeating it. I would really very much, as a former practitioner of the dark arts, love to hear a politician in today's federal election campaign, I don't care what ideology or political stripe, describe for me a vision of health care for the 21st century and beyond for Canada. You couldn't do that in a 6-second clip. From upstream care, which I think is, I've been doing a lot of work with the Canadian Index of Well-Being, most latterly with Waterloo University, before that time with the Atkinson Charitable Foundation out of Toronto. I think if we made a huge step in this area, we would be probably eliminating costs and illness downstream very effectively, requiring less drugs. And I only throw that out to you because it's the one kind of challenging thought to the pharma issue which I have. The pharma issue because of the costs, simply that it's going, and it seems to be absolutely not on anybody, well, apart from Mr. Mulcair's radar screen, and the points that I made in my speech without repeating it.
Thank you.
Okay, I hope I answered the question. I don't think I quite did. Maybe one more, Kevin? Well, if it's an easy question.
I have a question. Earlier you mentioned limiting which drugs that this plan would cover. Wouldn't that mean that certain people with rare illnesses or illnesses that have that just require certain very particular drugs might not get the drugs that they do need if such drugs are limited? Like, when that...
No, I don't have that in mind. I don't have well, if science indicates that there's a drug which has very limited positive impact, there might be some debate about this. That's not the issue that I have in mind. The example that I use again. There are experts in this room, please help me out. I don't know how many anti-cholesterol drugs there are. Crestor, Lipitor, you name them. Maybe there are differences amongst them, I don't know. I think a national drug agency at least could measure over some time as to the effectiveness of them. But I think that we would find that one or two probably could do the job very effectively for almost everybody. There may be some rare exception. What we're getting here, which is what I railed against in my healthcare report, it's a bit off topic, is advertising of drugs on television and radio. Well, it's just burgeoned out beyond control now, and of course with the internet, it's really out there. Well, what is this intended to do? It's intended to promote to us watching, I'll say television to reflect my age, a particular program, that I may need to take a look and ask my doctor about this particular drug. I'm not going to mention the one that I might need, but leaving that as an aside. It's not the one you think. In any event, this is what I'm getting at. So I think it's so many facets of this thing because it's commercially driven. And if you and the farmers will tell you, well, we've got to have one or two successes in order to justify all the research which is going on. I think that there's some merit to that argument. There's no doubt about it. But surely to goodness, we don't need hundreds of same categories of drugs with competition amongst the drug companies in order to provide good quality assigned care, prescribed care by a doctor to us. That is what I'm trying to speak to. I'll say again, thank you very much, Kevin.
Thank you. Let's all put our hands together, everybody. Thank you, Mr. Romano, for coming to the University of Ottawa. Just a few other thank yous. I mean, just incredible leader. Notre symposium et allocution ce soir ont encouragé notre réflexion des questions importantes pour le futur du Canada. Cet événement fait partie d'une série de conférences qui sont financées par une subvention du Conseil de recherche en sciences humaines. I want to thank our panelists that are still here today. I know that they thoroughly, thank you for your participation. Thank you for staying with us for this important speech. I invite you to, we're going to continue this session. There'll be future sessions, and as we look forward on institutions and other political issues. Nous remercions notre doyen Marcel Moret et nos collègues de la Faculté de Sciences sociales, in particular notre équipe de communication et de marketing, Bridget Genier-Saint-Jean, Marianne Burgess, and Natalie Simmer. We'd also like to thank our University of Ottawa President Alan Rock and his team, former healthcare minister. We're fortunate to have, CPAC. Thank you so much for covering this, so the people around the country can, can listen and learn from the incredible panelists and from our speaker tonight, Mr. Roy Romano. And especially thank you to the students. You are the future. Thank you. You've heard from a great inspirational leader. You heard about commitment and compassion and not giving up on these tough issues. Thank you very much for coming tonight.